Hi, I'm Dr. Christopher Barker. Welcome to Holding Space. Today I'm holding space with Dr. Keith Morgen, my coworker and quite an accomplished person in a great many ways. I really like having guests on this podcast because it gives me a chance to not only just stare at the camera and talk to myself, but also to have interesting points of view and have other people's perspectives on things. And I guess I'll just give it to Keith at this point to get started. And hi, welcome.
Right. Thanks for having me. We had discussed possibly having a discussion, you and I, about, some concepts that are relevant to what we do, things such as resiliency and hope and, how somebody needs to build some of that stuff in order to more effectively engage in whatever type of issue they're in therapy for so they can sort of grow towards something. Something that I'm really passionate about is we always say people are in recovery from something, whether it's recovery from addiction, recovery from trauma. But in reality, even though it does start off that way, at some point it has to transition from recovery from to recovery towards. And sort of looking at, what I look at through addiction and co-occurring disorders is how to conceptualize the therapeutic process through basically a post-traumatic growth type of model, where at some point the person has to be recovering towards something, towards new meaning, towards happiness, towards a new perspective on life, towards having to sort of make peace and learn how to coexist with what had happened in the past. And I think that, that'd be the stuff I like to have a conversation about today. 'Cause I think it's really relevant, not just for recurring work, but to psychotherapeutic work in general.
And you're right. I mean, I like the idea of recovery towards. I was just reading something by Viktor Frankl, and I'll do a podcast on that in a day or two. About the meaning of life and the meaning that we find in living, and also, I mean, resiliency is something that
Mhm.
is you know it's been in the news a lot. I mean, they've been working on it and they've been identifying things that make people resilient. But, as far as what brings resiliency to individuals and what effect that it does have on therapy is very interesting to me.
I think one of the things that I've examined both in my books and some articles and conference talks and just in when I teach either the students in our counseling program or supervise postmasters people logging hours is the role that hope has to play in building resiliency. If you think about what got me going on this mindset, this point around 10 years ago, is there's in the language of AA, there's something to the extent of basically, A doesn't turn away anybody who wishes to recover. Basically, what it says, we don't turn away we don't turn away anybody who wishes to recover. But if you really think about it, to wish to recover is to hope that recovery is possible. And hope is, I think, the most powerful part of all of this because hope, in my opinion, is the building block toward resiliency. You don't build resiliency on the sidelines. You don't build resiliency. Let me think about how to be resilient and plan it all out before I go out there and I do it. Resiliency is really built on a very difficult foundation. And I always find it fascinating, and I discuss it all the time, that to build resiliency as a therapist with our client, we have to sell them on something that is not necessarily all that ideal of a product to them, which is that you have to be resilient, start walking toward the thing you've been running from. And that's a hard sell. And to ask somebody to do that, there's got to be at least a molecule or two of hope in there that what I am doing will lead to something better. because otherwise, who's going to do all that work and engage in all that pain and struggle and embarrassment and shame and guilt and everything else that comes along early in therapy to walk toward the thing to become resilient if they don't hope there's a benefit to it?
Yeah, usually people are so focused on moving away from the problem. They've been
Yeah,
doing some podcasts about that recently about how that's not really necessary, that, you can't spend all your time focused. Well, I mean, if you're focused on the problem, then you're focused on the problem, whether you're
yeah,
looking on letting go of it or whether you're embracing it. But sometimes you can just acknowledge it and just move past. But even if you acknowledge, okay, yeah, I'm an anxious person, but then what's on the other side of that? What am I hoping to be? What am I
yeah.
hoping to become? And
I
how
also
do I
find that
establish
sometimes,
that?
like sometimes people also in therapy, when they hit a wall or when they get to be a little bit too vulnerable for them, they sort of engage in this sort of permission structure to stall out. That's just who I am. I'm just messed up. I always do this. So it sort of starts to build this sort of soft landing off ramp that, this got to be a little bit too much and I'm just messed up. That's who I am. So they're just going to not continue with it. And that's always a real challenging thing because, from more of an existential perspective, looking at things, you're talking to people about, issues of surrender and confession and essential limitation, being able to engage with where they have flaws, where they have deficits, and be able to engage with them and learn from them and grow from them, and also see that progress is not completely turning everything around. That if you early on basically emotionally limp through your day, but you get through your day and you don't self sabotage and you get some stuff done and you don't, slide backwards, that's a win. And I think that is the hardest thing for a client to begin to sort of take hold of, that this is progress. So I always discuss with my clients and students and my supervisees emotional, mental health, recovery, stability is never the absence of negative. It's how you manage negative. And I think that's all the pieces of therapy that sort of wrap around whatever theoretical orientation you're trying to engage with somebody.
Yeah, and progress is not linear. I mean, it's not like I go from here to here. It's, that famous diagram of like this is how progress looks, and there's squiggles in the middle.
Yeah.
Yeah, there are ups and downs to that, but even so, like you said, if you get through the day, you got through the day, and that's still a victory. Those are the wins.
But I find like a lot of people, especially if they're relatively new to therapy or they've been through this a lot before and it hasn't really worked for them effectively before. They sort of have the I have a headache, let me take a Tylenol type of perspective that, this should be resolved in about 30 to 40 minutes. And when it's not being resolved, what that say about me? Yeah, am I too messed up to get any help? Because this is never going to change. And all that stuff just reinforces all that negativity in the first place.
Yeah, it's funny. I mean, I keep a magic wand on my wall in my office as a symbol because people ask for one from time to time. Can't you just wave a magic wand and fix me? Well, it's not like that. It's not an instant process. There's no switch that automatically you can turn on and off, and there's no magic involved in it. It's work.
Yeah. I mean, that's why I agree with you. And that's why, I always joke around. I'm like the only therapist that doesn't like the phrase coping skills. I don't like coping skills as a phrase because it feels to me like you can go to Home Depot aisle 5 and find a box of coping skills and take them home and there's something concrete to it. And like you said, it's non-linear. So I would like, instead of you're coping with, you're coexisting with. I always find the term coexisting just to me as more of I'm getting my hands dirty and I'm working on this and it isn't going to maybe go all that super at first, but I'm coexisting with it. And a more adaptive way than in the past where I would be sitting with it and it would be overtaking me somewhere.
Yeah. Yeah, I like that. You're existing with, and, again, that sort of like puts you in a less adversarial relationship. You don't have the problem as separate from yourself. You don't have the process of therapy as something separate from yourself. It's something that you're united with, and you're changing, but it has to be present with you.
Yeah. And I like what you said because it aligned with, for example, in the co-occurring realm, addiction, mental health, the individual is using substances or sex or gambling to try to cope with or coexist with the negativity by just zapping it away, escaping it. They're never running toward a high, they're running from a hurt type of thing. So, but what happens there is if you think about this coping skill, coexisting skill as a muscle, every time they had done that cycle of negativity use, okay, it's gone, then it comes back again, I need more of it. They've atrophied that muscle to the point where when they are in recovery and they are ready to start, that muscle has been atrophied to the point where it's so weak that it's a remarkably heavy lift for them dealing with anything negative because there's so much history that they've learned very accurately if I do this, if I drink, if I gamble, I can get rid of the negativity for a while. And that's a really ingrained skill set developed in themselves that takes a long time to shift, primarily because when they first start out in recovery early on, they don't really have anything else to go with other than sitting with that negativity and slowly growing resilient to it. And if there's not some grain of hope that this is going to yield something, then, you know, it's sort of, I always say that's a good explanation in part why relapse is so high because they get hit with negative when they're in early recovery. All of their non-addictive skills for managing negative have atrophied to basically nothing. And back in their head, they're hearing, "Hey, there is one way we can deal with all this negative," and it's gotten to the point where they just are, I think in the RABT language, they call it discomfort anxiety. Just like I can't sit with negative to the point where I need to escape with negative.
You had some, I think you said you had some diagrams.
I do. I can see if they come up. So let me see if this works or not. Try this one first. If it doesn't work, we'll just call it a day.
The idea of the muscle atrophying, that really resounds because,
Yep.
if you don't work it, if you don't use it, you lose it, so to speak.
Okay. Do
And
we see this?
I can, yes.
Okay. Then it actually worked. All right. Cool. So this is a slide from one of the first weeks in my course on co-occurring mental health and addictive disorders. Basically, just shows what we were talking about. That um, the negativity of symptom in this case is PTSD, but it could be anything. The negativity of symptom fuels into the addictive process, which does provide some real relief, but you atrophy any non-addictive ability to manage that. The next time a symptom comes around, you're that much more inclined and I need to use this. And that's a big thing, for example, in the addiction literature, the idea behind expectations. Uh, in some ways, it's the expectation of, I can't do this without whatever the addictive behavior or the substance is. And just think about how many times you hear people say, I can't start my day without coffee, or, I can't get through my day without the first cigarette. It's the same type of thing. Um, what the person has told themselves is, well, I absolutely cannot do this without this thing. And if they buy into that belief system enough, they need that thing. Otherwise, it becomes almost like the self fulfilling prophecy. So, a
Yeah.
lot of what we do in therapy early on, I think, is just try to help the person reconceptualize how they are in the world and how they engage with negative, and then begin to look at what they have been doing to engage with negative, and by their being in therapy, by their being in recovery, they're sort of saying, well, these prior maladaptive, dysfunctional, things I was doing and are now off the table. So how do I engage with this? And I think if the client sort of understands this on a basic level, they can sort of understand some of the stuff that's going on in them, such as, why do I feel I have this expectation of I need this thing and to get through my day. So if they begin to understand it, I think all that knowledge is some of the stuff that seems to maybe fuel the sense of hope that, okay, well, if I understand this, there's hope. So I'm willing to sit with this negative because I'm building something healthier instead of just, doing something dysfunctional to cope with my negative.
I love the idea of substituting hope for the substance abuse or the maladaptive coping skill in there because you're right. I mean, I love that diagram because, yeah, you have the symptom that leads to the substitute method of coping. And then, that becomes okay, so now I feel better, but it hasn't really solved anything. So if you take that out, behaviorally speaking, it takes time for that to extinguish. And so, what do you have to take the place of it? You have to have something else in there. So, you have to be building hope and resiliency. And again, some of the things they talk about with the building resiliency, contact with other people, working on, something, having something special to be working on, purpose. These are things that build resiliency. And if you have those, you don't really need the crutch anymore. You don't really need that other coping skill.
There's an article by now, it's probably about 22, 23, 24 years old. It was basically looking at this notion of in the addiction and the co-occurring field, how do you define spirituality? And it was an article that looked at all the different ways articles and theory have tried to define this concept of spirituality. In the end, it really came down to spirituality is having meaning in life. And I think I always find it fascinating when I ask, students or I ask clients, are you spiritual? Oh, I don't believe in, but you have a meaning and purpose in life, or you're working towards a meaning and purpose in life, and that's spirituality. And I think even that ties back into hope. Um, Step 4 in the 12 steps, talks about the person engaging in a fearless moral inventory. And I don't think they just threw around word just for the creative flair. They put the word fearless in there for a reason. The fearless thing is basically a call to action to build resilience. That when you start doing step 4, you start thinking about, you know, who you were and what, you used to be and where your deficits are and your flaws are and how they manifested. And you really start to get into that guilt and that shame and that regret. There's going to be a big pull. There's going to be a big inclination for you to sort of, okay, this has gotten too hot, so I'm going to stop here. It's just too much. And I think I always felt that word fearless is in there because it's basically saying when you are there, that's when the work is just starting. And the resiliency building, push forward more. If you feel that negativity, thinking about yourself and how you used to be and what you did, push through more. And just I think you see that all over therapy. I mean, if you see it just from the basic standpoint, for example, existential therapy, looking at going from neurotic anxiety over to existential anxiety, where in neurotic anxiety, it's sort of like, how are you keeping yourself sort of buffered and distant from what you know is really going on? To where we're into more existential anxiety, which is all right, you feel angst, you feel nervous, you feel worried, you feel stressed, you feel negative about you, but it's because you're grounded in what's going on right now, and you're not trying to act as if and keep it distant. So I think always down across any theoretical orientation, you always have this notion of resiliency.
Thank you, Keith, for joining us today. And Keith's written a couple of books on, well, you can tell us about the titles of those. And he teaches at Centenary University, and that's,
A professor of counseling and director of the graduate counseling program at Centenary University out in Hackettstown, New Jersey, Warren County. I've written the first and second edition of Substance Use Disorders and Addictions textbook with Sage, and I've written, along with my colleague, Dr. Mashi at Fordham University, Aging Behind Prison Walls, Studies in Trauma and Resiliency, and that looks at a lot of these issues in the older adult population in prison.
maybe we can do another one at some point in the future on that, because I mean, that is definitely, that's a place that's going to be hard to build resiliency. It's going to be a place sometimes that discourages hope. But on the other hand, that's exactly what you need in order to get through.
Yeah, you want to do that? I can also have to see if Mashi would want to join. We could have me and her together on to
Okay,
talk about it. Yeah.
cool. That'd be great. Thank you, Keith, and thank you everybody for holding space for us. And we will see you soon. Remember to hit like and subscribe. If you have questions, if you have comments, please feel free to leave them. I respond to those as quickly as I can, and sometimes they led us to some really great topics in and of themselves. So you give me ideas in addition to, hopefully, we give you some ideas too. Thank you all for tuning in.
Thank you. Appreciate it.
Thanks.